ويشرفني أكون مع حضراتكم طبعا. Next lecture, lung transplantation, دكتور علاء حمدي.
Good evening. Post-operative complications of lung transplantation. The first successful isolated lung transplantation procedure was performed by Toronto General Hospital in 1983. Lung transplantation is now an accepted therapeutic option for patients with end-stage lung disease. However, as a complex surgical procedure, multiple complications are encountered. The most recent International Society for Heart and Lung Transplantation reports 1 in 5 year survival rate of 85% and 59% respectively. Early and accurate diagnosis of complications can be challenging. Several of these complications may coexist, resulting in complex radiological pictures. Radiologist awareness of imaging features of complications that may occur at varying time points following transplantation is essential to effectively guide clinical management. Indications of lung transplantation: obstructive lung disease such as COPD, restrictive disease as end-stage pulmonary fibrosis, infectious disease, cystic fibrosis, vascular disease as pulmonary arterial hypertension, veno-occlusive disease. Some surgical consideration: 3 transplantation procedures are commonly performed: single lung transplantation, bilateral, and heart-lung transplantation. Single, from living donors or when a lung from a deceased donor is too large for the recipient's thorax. Bilateral, typically preferred due to longer post-transplant survival, decreased risk of bronchiolitis obliterans compared with unilateral transplant, particularly among patients with COPD, infectious and vascular lung disease. Bilateral lung transplantation is performed in patients with infectious lung disease because if single lung is only transplanted, the native lung may be a source of infection. Also, in vascular causes, single lung transplantation may lead hemodynamic instability, and thus bilateral lung transplantation is preferred in vascular diseases. Patients with obstructive or fibrotic can undergo either bilateral or unilateral. A wide range of complications can occur after lung transplantation, many of which can be diagnosed at imaging. These complications can be categorized either allograft rejection or non-rejection. Complication can be also organized on the basis of their temporal relationship with the transplant surgery: immediate, early, intermediate, and late. Immediate, hyperacute rejection, it occurs within 24 hours. CT features are non-specific features: extensive consolidation, ground glass opacities, and septal thickening. The second immediate complication is the donor-recipient mismatch. If the donor lung is too large for the recipient, passive atelectasis may manifest on immediate post-operative chest radiograph, and superimposing complications in the atelectic lung may lead to scarring and vessel reduction in the lung volume. Undersized donor lung can result in mechanical problems related to residual space, such as intractable pleural effusion or pneumothorax. Acute complications such as pleural complications, pleural effusion, pneumothorax, hemothorax, or primary graft dysfunction. Primary graft dysfunction is a complex multifactorial process, can be attributed to reperfusion edema, reperfusion injury, non-cardiogenic acute lung injury, may improve by the end of first week and resolve by day 14. Radiological imaging are middle and lower loop predominant airspace opacities, mixed airspace and interstitial opacities with bronchial vascular wall thickening. This is a CT for a 49-year-old male, deteriorated clinically after 7 days. CT scan: here we can see a focal fluid collection in the left anterior hemithorax with containing gas suggestive of empyema. We can also see a large focal collection in the right basal hemothorax with higher attenuation, and diagnosis was confirmed as hematoma. Intermediate complications are acute rejection. It's a cell-mediated immune response similar to primary graft dysfunction in CT features. However, it has a significant improvement of radiological abnormality following IV steroids within 48 to 72 hours. Or anastomotic complications: airway and bronchial anastomosis, pulmonary artery and pulmonary vein to left atrium. Here we have a CT for 53-year-old woman, deteriorated 5 weeks after transplant. We can see here bilateral ground glass opacities, pleural effusion, and septal thickening. Then the other CT is for the same patient obtained 2 months later, show resolution of the early imaging findings. Airway anastomosis, it occurs in 15% of bilateral lung transplantation. Early complication is dehiscence and infection. Late complication is stenosis and bronchomalacia. Advances in multi-detector CT technology and ultra-thin bronchoscopic technique have facilitated early detection and management of airway anastomosis. Risk factors are recurrent rejection infection, donor bronchus ischemia, disruption of the native bronchial circulation. In this case, we have a 28-year-old woman, 11 days after lung transplantation, developed persistent bilateral intractable pneumothorax in spite of the chest tube inserted bilaterally. However, it has recurrent pneumothorax. The cause was revealed on CT. We have here focal defect at the right bronchial anastomosis with extraluminal air, and thus the diagnosis was dehiscence. Also, we have here left lower loop pneumonia with consolidation and atelectasis. 36-year-old man developed bronchial stenosis 6 weeks after bilateral lung transplantation. Vascular anastomosis, arterial complication is much more common than venous. Risk factors are excessive length of the vascular pedicle, short allograft artery length, restrictive suture and clot. Contrast enhanced CT angiogram may show narrowing or occlusion leading to non-resolving pulmonary opacity secondary to lung infarction. We have here post-left lung transplantation with peripheral wedge-shaped multifocal consolidation in the transplanted lung. Axial contrast enhanced CT show abrupt occlusion of the proximal left main pulmonary artery, and we here have the 3D colored imaging showing the same features. Infections. Lung transplanted patients, as patients of transplantation, has a particular risk of allograft infections. First, post-operative are associated bacterial and fungal. Bacterial infections, patchy consolidation, centralobular nodules, cavitation or abscess formation, while aspergillosis, central nodular consolidation with peripheral ground glass halo sign consistent with hemorrhagic infarction. We have here 26-year-old man, 1 month after transplantation. We have multiple nodules, ground glass, and the cavitation. Aspergillosis was confirmed. A long-term immunosuppression of T cells are responsible for the viral pneumonia. CT features are ground glass opacities, 3 embodied nodules. Fungal and parasitic opportunistic infections, either cytomegalo or community-acquired nosocomial infection. After 6 months, immunosuppression is usually reduced with less opportunistic infection, and the most commonly are community-acquired, either viral or bacterial, or reactivation of latent Mycobacterium TB. Late complications are chronic lung allograft dysfunction. Bronchiolitis obliterans, it occurs 3 months or more after lung transplantation with progressive decline in the forced expiratory volume. We have here a 55-year-old man with single lung transplant. CT features are showing mosaic attenuation of the transplanted lung. The native left lung here is fibrotic. 1 year later, this right lung developed pulmonary fibrosis. Imaging features of bronchiolitis obliterans are mosaic attenuation, bronchiectasis, and bronchial wall thickening. Restrictive allograft syndrome. Clinically persistent decline in the forced expiratory volume with decline in total excited count. Persistent opacities at the chest imaging that last for longer than 3 months despite treatment. Here we have 44-year-old male with cystic fibrosis, have undergone bilateral lung transplantation with bilateral upper lung and pleural fibrosis compatible with the restrictive allograft syndrome. Malignancy is an important cause of long-term mortality. With post-transplantation lymphoproliferative disease include a spectrum from lymphoid proliferation to monoclonal lymphoma. Manifestations are either isolated nodule or mass, disseminated micronodules, mediastinal or abdominal lymphadenopathy. Skin malignancies are also predominant, include melanoma 20% at 10 years. Other cancers can also occur such as primary epidermoid lung cancer. CT scan here show multiple nodules with surrounding halo of ground glassing. Percutaneous CT guided biopsy confirmed diagnosis of post-lung transplantation lymphoproliferative disorder. To summarize, these are the most common complications encountered after lung transplantation. corresponding to the timeline. Surgical complication, size mismatch, bronchial dehiscence early and bronchial stenosis late, alloimmune response, acute rejection early and chronic lung allograft disorder, infections early bacterial, late virus and fungi, malignancy or late complications as we described. Lung transplant can vastly improve quality of life for patients with end-stage lung disease. Radiologists are critical members of the transplant team, either before and after transplant. Correlation of the clinical radiological features with the time course significantly help in narrowing the differential diagnosis. As the number of patients who undergo lung transplant continues, it's essential for the radiologist to have a thorough knowledge of the imaging of lung transplant and to understand the clinical aspects of lung transplant that are relevant to imaging. Thank you.